Welcome to the 5-Minute ECG Consult, brought to you by Troy Kennedy, Doctors John Hayden, Jonathan Barney, and myself, where we guide you through the basics of ECG interpretation based on the primary survey approach in Dr. Hayden and Dr. Barney's book, ECG for First Responders, available on Amazon. Let's get started on today's case. You arrive on scene to find a 58-year-old male who presents at home with weakness, nausea, vomiting, and shortness of breath. He is an obese male who states that he's experiencing worsening weakness, nausea, and vomiting over the past 3 days. He's decided to call now due to dyspnea. When you attempt to take a blood pressure reading, the patient advises he has an AV fistula for dialysis in the left upper extremity. Based on the scenario so far, is there any additional information from the patient that is pertinent to ask? Hopefully, you would ask more about his dialysis schedule, because after inquiring about his dialysis schedule, he admits that he has not had dialysis for a week. His past medical history is significant for ESRD, type 2 diabetes mellitus, hypertension, hyperlipidemia, CHF, and a knee amputation. When asked about his medications, he says, "I don't know, I take so many. There's got to be a list around here somewhere." You obtain a 12-lead ECG, but before we examine it, let's review our primary survey of interpretation. We use the Ecg Primary Approach to quickly identify possibly life-threatening emergencies. In this approach, we seek to answer these 4 questions. 1. Is their heart rate too fast or too slow, causing cardiovascular instability? 2. Is the rhythm supraventricular or ventricular in origin? 3. Are the ST segments consistent with ST elevation myocardial infarction, STEMI, or a non-ST elevation myocardial infarction, NSTEMI? And 4. Are the T waves consistent with the STEMI or an NSTEMI? With this in mind, let's take a look at our patient's ECG. First, the rate. Despite the wide appearance of the QRS complexes, determining the rate is no different than any other rhythm strips, and the 300, 150, 100, 75, 60, 50 method can be applied by measuring the R waves falling on bold lines. Here we find that the rate falls between 75 and 60, specifically on the third line, which correlates to 65 beats per minute. Next, let's look at the rhythm. Looking at lead 2 rhythm strip on the bottom, we note that the wide sine wave appearance lacks a formal PQRS-T morphology. The R to R intervals remain constant and regular. There are no appreciable P waves given the wide morphology of the QRS complex. Given this, we cannot definitively state that this is supraventricular or ventricular, but keep in mind that this sine wave pattern is only seen in a few circumstances. Next, let's look at the ST segments. We are unable to truly appreciate the ST segments given the wide sine wave pattern. When in doubt, if the patient has symptoms suggesting an acute coronary syndrome, follow appropriate protocols and transport to the appropriate facility. As always, you should consider an expert consultation with medical control. Lastly, let's look at the T waves. As with the evaluation of the ST segments, the wide sine waves appearance hinders the evaluation of the T waves. Remember, even in the presence of rhythms such as this, it is important to follow the primary survey for rate, rhythm, ST segments, and T waves in order so as not to miss important clinical cues. Let's test your knowledge. What do you think? Given this patient's history, clinical presentation, and ECG, which of the following is the most likely reason for the ECG findings? A. Hypokalemia. B. Hyperphosphatemia. C. Hypocalcemia. D. Hypomagnesemia. Or E. Hyperkalemia. If you need a moment, pause the video to review the answer choices. It's not A. Hypokalemia. It's not C. Hypocalcemia. It's not D. Hypomagnesemia. And it's not B. Hyperphosphatemia. The correct answer is E. Hyperkalemia. Now, as a follow-up, recognizing the severe hyperkalemia in this patient, which of the following would provide the most benefit in a pre-hospital setting in addition to IV fluids? A. IV furosemide and morphine, B. Synchronized cardioversion, C. IV amiodarone, D. IV calcium chloride, or E. IV adenosine. Once again, feel free to pause the video before we reveal the correct answer. It's not E, IV adenosine. It's not C, IV amiodarone. It's not A, IV furosemide and morphine. And it's not B, synchronized cardioversion. The correct answer is D, IV calcium chloride. As a side note, sodium bicarbonate may be indicated for metabolic acidosis in some instances, but potentially increasing fluid volume due to sodium may exacerbate the situation. Rely on medical control for direction. Here are the key takeaways from today's lesson. Dialysis patients who miss appointments may present with hyperkalemia, and an ECG should always be checked to assess for peaked T waves or sine wave morphology. The unusual wide, slow sine wave pattern shown in today's lesson represents severe hyperkalemia, which requires rapid transport to a hospital and emergency treatment. The administration of calcium helps to stabilize the membrane of cardiac myocytes, decreasing the likelihood of potentially lethal cardiac arrhythmias. The administration of sodium bicarbonate may reverse the concurrent metabolic acidosis, which occurs due to the shift between hydrogen and potassium ions at a cellular level during hyperkalemia. As always, follow your local protocols or consult your medical control physician prior to giving these drugs, particularly regarding the sodium bicarbonate, to prevent volume overload. Recognize that severe hyperkalemia presenting in sine wave ECG may initially be mistaken for ventricular rhythm, such as accelerated idioventricular rhythm or ventricular tachycardia. Well, that's all for today. We hope you enjoyed this edition of the ECG 5-Minute Consult. If you'd like to learn more about ECG interpretation, check out our book, ECG for First Responders, available on Amazon. Thanks for your support. We look forward to seeing you next month.